Good evening, everybody, and welcome to the Long COVID Clinic, What You Can Do, with me, Dr. Binita, Kane, and
I'm Helen, Oakleigh, passionate advocate for the charity Long COVID Support.
And tonight we have the next in our Fireside chat series, and we've got a really brilliant session lined up for you. So as usual, Helen is going to pop backstage. We'll be keeping an eye on the chat. Please remember it is live and interactive, so do put your questions in the chat. We shall go through them and try and answer as many as we can. And the session is recorded, so if you have a foggy brain or fatigued and you can't manage the whole session, don't worry, it will be available on the YouTube channel immediately. So without further ado, I shall put Helen backstage. I'll see you later, Helen.
See you in a bit.
And it's an absolute pleasure to introduce my guest for this evening. So welcome Dr. Jen Curtin, who is a physician who is based in sunny San Francisco in California. So thank you for joining us from the other side of the world. She is the co-founder of Rhythm, which is an organization that has been set up to treat people with complex chronic illness that's poorly understood in a holistic way. And she works with a team. And it's just fantastic to have you on. I'm really excited to hear about the work that you do, Jen. So welcome.
Oh, thank you. Thanks for having me.
And I just thought that I'd start, if you don't mind, just giving us a brief kind of history of kind of what inspired you to set up this organization and the work you do.
Yeah, so I mean, I feel like people who go into this area of medicine have either some experience, either personally or with their family. For me, it was both. So I had ME/CFS. I developed it fairly sudden onset in college. And basically, also several of my family members did as well. And so we had this long odyssey of trying to figure out what was going on. You know, it wasn't diagnosed right away. It took many years to get the diagnosis. And then just that kind of medical journey of trying to figure out what was wrong with me and what was wrong with my family was so arduous. I did, with the providers I was working with and with all of the reading and everything we were doing, I was able to get to the point where I would be considered mild. And so I was able to go to medical school, and ideally I was kind of trying to figure out, okay, if they can't really solve what's going on, can I figure it out? Get the training and see what this is all about. And so it was fascinating going through medical training as a patient and, you know, a clinician in training. So I was kind of getting worked up as I was training. So it was a very interesting experience. But I did eventually was able to find out a lot of the things that were problematic, and many of which had just gone on most of my life and just weren't picked up. And so once a lot of those were managed and treated, I actually went into remission from ME/CFS back in 2019. So the PEM, the sleep issues went away. Still have a little bit of the word finding issues, but and I do have POTS, but it's fairly mild now. I still have a few remaining things that are actually a different category of conditions, but all of it was just a very interesting journey. So this was definitely a personal odyssey for me.
Amazing. And we're also grateful that you have taken your own experience and are now helping many, many other patients. So I understand that your service is kind of servicing 11 different states or 12 different states at the moment. So you see people from lots of different areas at distance, and you really cater for people who can't travel. Which is brilliant. And maybe we will get onto that at some point about how you do that. But there's so much to cover in this session. I'm going to move swiftly on. So one of the things I know that you have done is you are part of the clinical coalition in the States that has produced guidelines for ME/CFS. And this is something that we do have a sort of a guideline in the UK that's been developed by NICE. But I know that you've developed quite a different type of set of guidelines. Can you tell me a little bit about that?
Sure. So the Clinician Coalition is a wonderful group. Mary Dimmick organizes all of us, and she does a wonderful job. And basically it's providers with experience in ME/CFS from across the United States. There's a pretty significant group of us. And essentially, it's just kind of pooling sort of expert opinion and literature into what can we distill into a workable set of diagnosis and management guidelines that other providers can use when they're working with these patients. Because as you all know, this is all stuff that you don't really learn about in your medical training, or very rarely are a lot of these taught. And so it includes things like talking about what different conditions to consider and help rule out, what testing you can do, what sort of treatments you can do, talks about pacing, all kinds of things in there. And I think probably you're going to drop the links to these documents afterwards so that people can reference them. And they're a great resource that if you have a provider who's maybe open-minded enough to look into something and try things, these are a great resource to give to them so that they can help you with your condition. And there's also a lot of other resources on the ME/CFS Clinician Coalition page. There's actually training videos for clinicians that you can get, at least in the US, you can get CME credit, continuing medical education credit for it. I don't know if that would apply over for UK clinicians, but there's a whole bunch of resources on there. So it's a great website to explore, and there's a lot of gold nuggets in there.
Amazing. And we will definitely be posting those links. We'll try and put them in the chat as we go along, but we will definitely post them underneath the recording so people can access those. And I think that's the difference, that what we don't have in the UK at the moment is the treatment guidelines. So we've got the NICE guidelines, which do focus on diagnosis and how to manage some aspects of ME, but we don't have the kind of, well, these are the different conditions and these are the drugs you can use, and here's a guide of how to do it if you don't know about ME. And we really do need to develop that as a country. So yeah. And has that been received quite well in the States?
Yeah, it has been. So I think the original kind of paper went out in, I believe it was like August of 2021 in Mayo Proceedings. And it did get quite a lot of views. So that's always good when people are actually downloading it, reading it, sharing it, that kind of thing. And so, there's also been a lot of follow-up in terms of, the components that you see. So there's a lot of management of sort of overlapping conditions that co-occur or frequently are comorbid with ME/CFS. So for instance, as many as like a third of people will also have POTS or some form of dysautonomia. Orthostatic intolerance is very, very common. And it's also, there's like connective tissue disorders that show up. There's, frequently comorbid people may have various types of like EBV reactivation, HHV6, various kinds of viral issues. You have to look for, different kinds of other chronic infections that may be subtle. So things like Lyme disease and vector-borne illness as well. Sleep disorders need to be looked for. They're autoimmune. There's a whole bunch of things. And then based on kind of what you find, there's a lot of different treatments you can use to address those different subsets. So, there's really a lot that can be done. I think one of the hardest parts as a practitioner treating this is really trying to figure out, okay, there's so many things that you have to look through that there's a lot of testing. And that testing can be kind of burdensome on the patient. It can be tough because this one place runs this test, but this other place runs the other one. And this other place runs this test. And so people may be going to different areas to get them. And the costs can add up as well in terms of all of the workup and the testing. So that part can be challenging. The other component is, okay, now you have all this data. What if you get a picture that isn't like clearly one thing or the other, or you get everything lighting up? Like, oh, this person has autoimmunity, they have a sleep disorder, and they have mast cell activation, and they have GI dysbiosis. And it's like, okay, where do you start? What do you do first? And so those are actually, to me, more of the more challenging pieces.
Okay, so I'm going to just unpack some of that because some of the people listening may not have understood all the words you used there, but I think if I could try and summarize that as, we know that ME there's lots and lots of associated syndromes and conditions with ME that are treatable, that can be managed, but can be tricky to diagnose. And I think one of the challenges we have in the UK is that people are not doing the right tests. So people will come to me and they will have had a whole bunch of standard tests, which come back normal. And then they are told, therefore, there's nothing wrong. You're just a bit anxious. Off you go, do some exercise and think yourself better. That's kind of how people are treated, sadly. And that's just a story I hear over and over again. And then we don't have access to the right tests. So without going into too much detail, because I know this is a massive topic, what are the kind of tests that you would think are standard for your ME patients? Say they've had the usual kind of routine blood tests, chest x-ray, ECG, those types of things. People can access that here. What are the additional tests that you do?
So, some of this is guided by the history that you take. So depending on their symptom profile, but I would say for the vast majority of people, a sleep study would be important. Ideally overnight, because you need the sleep architecture. And also it's easier to test if someone has upper airway resistance syndrome, which can mean when your airway isn't fully, so if this is your airway, it's not like fully collapsing, it's just kind of getting a little narrower. And so you may not snore, but it's a lot more work to breathe through a tube that's this big than one that's this big. And so it can elevate pressure in the head. It can also elevate blood pressure. It can change a bunch of things and stress your body out pretty significantly. So that still may cause issues. Also, sometimes there are just like other sleep disorders that are going on. And sometimes like occasionally you'll pick up a case of like narcolepsy, which is interesting. And the other things, so if they haven't had like an autoimmune panel, so like an ANA cascade, usually that's helpful. Occasionally you'll find low levels of certain antibodies. I would say Hashimoto's thyroiditis tends to be a fairly common overlap. And so finding that is important because generally speaking, even if you have a TSH level, which is sort of thyroid stimulating hormone, it's what's kind of generally checked in terms of thyroid levels with most GPs. If that level is, let's say, a 4 or like a 3.5, that may be fine for someone who doesn't have Hashimoto's, but you kind of need to get that TSH down a bit lower, below 3, below 2, even in some cases. If someone has Hashimoto's going on. And that can be, so knowing whether or not there's Hashimoto's involved is important. Also, there's certain dietary things you may try and certain supplements and various things to help if there's an autoimmune component. Other things would be like infectious disease workup. So looking at various kinds of antibodies against viruses, the herpes virus family. The vast majority of healthy adults have things like Epstein-Barr virus, HHV6. A lot of us have CMV. And some of these, you want to check for them because once you have them for life. It's like when you get chicken pox when you're a kid. And then, it just kind of hangs out. Most people aren't bothered by it ever again. But then when you're older, let's say you have your immune system gets suppressed, you might develop shingles. That's the chicken pox virus coming back out and causing a problem. And all of these viruses can do that. It's just, they may not be as visible or as obvious or distinct as shingles, but they can all kind of do this. And so looking for those and trying to see, are they reactivated can be helpful. Also, just making sure testing for HIV if the person's never been tested, testing for hepatitis C and B, tuberculosis, and various different things like parvovirus, West Nile, if you're in an area where West Nile occurs. And also looking for things like the vector-borne diseases, so Lyme disease, Ehrlichia anaplasma, Rocky Mountain spotted fever may not apply for you guys, but basically looking at which ones are in your location and checking for some of those. Because there is a surprising number of people who actually turn up positive.
Yeah. So some of those things we can definitely access in the UK. So just for anyone listening, you can get an autoimmune screen. You can get tests to look for Hashimoto's, which is a type of thyroid disease. you can do some of the basic screening for the viruses, but what we don't really have is those more detailed viral panels that really give us, the T cell response, for example, to the viruses. You have to send those off to Germany. That we can get them, but they're expensive. You have to send them abroad. Our UK labs, for whatever reason, don't seem to do them as standard.
Can you guys get the PCRs or not really?
Not very easily, no. So I think so we are kind of really behind the States, definitely, in terms of that viral reactivation piece. And sleep studies can be done, but they're not very easy to access. There's long waiting lists now in the NHS for all of these things. And unless you are highly suspicious for sleep apnea, it can often be difficult to get them, or you have to see a specialist before you can get referred, So there are barriers to getting these things done, but it's useful to know that these are kind of the things that you consider essential for patients.
I mean, there's a whole bunch more. We could probably fill the entire time with just talking about the tests, but this would be a really great, if you want to reference the rest of the tests that are recommended, and they put them into tiers. So there's like the basic tier, which are the ones that probably you can get access to, CBC, CMP, and then there's kind of more advanced tiers that you can go to. It's broken down really nicely in here, and they talk about basically listing all the different kinds of testing. Now, I wouldn't necessarily say that like you have to get this in every single patient. You can, because it's a lot. You can break it down by, okay, if the person, it's broken down by like, do they have GI issues? Do they have pain issues? Do they have rheumatologic findings? So it's a really, really great
so that's the document. So that's the guidelines. So if people are interested in finding out more about the kind of recommended testing, they can have a look at, I think some of the links have been put in the chat actually. But I think it's this one, isn't it? It's that link, I think, which we've put in the chat. But don't worry, we will put it all in the YouTube, in the notes under the YouTube channel as well. So thank you for that. Let's kind of move on to treatment. So some of the other sessions that I have done or I've got planned on the channel for these live streams have covered things like POTS, and we're going to have a session on MCAS in December. We've covered kind of hormones. We've covered some of the big topics. One of the things that I'm really interested in chatting to you about is this viral reactivation, because there's a lot of people at the moment who are really interested in antivirals. The viral reactivation theory, that definitely plays out. I do see people who have had access to the tests, and they definitely have these viruses that are reactivated, but then we don't really know what to do about it. Because we don't have any clear guidance here about how you treat these things. So what's your approach to using antivirals, and to the specific question about viral reactivation? So we'll talk about Lyme in just a moment. And how are you seeing any differences from the pre-pandemic patients to the long COVID patients? So big question there.
Yeah, so going through, I guess I can give a little bit of kind of history of the antivirals. So there were there's work even back to the 1980s on looking at particularly Epstein-Barr virus and ME/CFS. And then additional viruses were kind of added to that and looked at over like the 90s, the 2000s, et cetera. And so several different studies have actually tested antivirals in ME/CFS populations and looked at the outcomes. And so there's kind of two major groups that looked at this. So Stanford's clinic, ME/CFS clinic, so it's Dr. Montoya, Dr. Kogelnick, they did some studies, and they looked at, basically they more used, I believe it was Fireside, and they treated patients with ME/CFS for about 6 months, and they looked at how they did. And if I recall correctly, I believe it was about half of them had like a pretty significant improvement.
What was the drug? Sorry, Jen, I missed that. What was the drug you just mentioned?
So actually, let me break down the different drugs that we use. So,
yeah.
So there's probably you guys have heard of acyclovir.
Yeah.
So that one isn't really well absorbed when you take it orally. So there was a different version of it made called valacyclovir. The kind of trade name in the US is called Valtrex. And so that one is fairly commonly used because of various studies that were done in the US by combination Stanford and Dr. Lerner over at, he was at, I believe they're Wayne State or University of Michigan. And so those are kind of, famciclovir can also be used. Famciclovir gets into cells a little bit better than Valtrex does. And so personally, I actually kind of like famciclovir a little bit better just because there's a little bit less of a risk of potential renal, like kidney issues. Although kidney issues with Valtrex are also very uncommon. And typically, if you stay well hydrated, you're not going to really have a problem. And then there's to treat viruses like CMV, HHV6. Those particular viruses don't respond to Valtrex, acyclovir, famvir, because of the way that there's a certain kinase that has to activate that drug, and it doesn't really activate it. So you actually need to use a different class of antivirals. So this is where Valcite, which is valganciclovir, or ganciclovir, and there's foscarnet. There's a couple others, but generally speaking, valganciclovir or Valcite, it's orally available in tablets. It's absorbed fairly well. That one has been studied specifically, and that one can have activity against HHV6, against EBV. There's also another antiviral. There's several others from the HIV world that have activity against Epstein-Barr virus. So one of the ones that's garnered a lot of attention more recently is tenofovir. Tenofovir is part of Truvada. So some of you may have heard of Truvada. It's being studied in long COVID. And Truvada is basically a combination of one of the, so it's a little bit complicated, but there's tenofovir is like the active metabolite. And then you've got two drugs that basically in the body, they get turned into tenofovir. There's TDF and TAF. And they're, from what I understand, I think one might still be on patent, so it's a bit more expensive, but Truvada is TDF and emcitabine. I always say it wrong. It's a long word with a lot of.
You're doing so well because these drugs are not easy to pronounce.
Yeah, I'm like, usually I just say Truvada.
Truvada, exactly. So much easier.
Yep.
Okay, so I guess I think the headlines there for me as this has been studied. I mean, I think there's a lot of people who go, oh, there's no studies in ME and we don't know how to treat this stuff. What is the ideal amount of time to use antivirals for? That's my first question. And the second is, do you use combinations of antivirals like we would do? The HIV regimes are all about using, more than one drug. And do we know the answer to that question really about what the optimal regime is? Because I know some people are put on really long courses, other people are given short, sharp, like, oh, here's like 5 days. And there doesn't seem to be any consensus amongst what different clinicians are even doing. So I'm just interested in knowing how you approach it.
So I generally put people on it for longer. The studies that were done usually did 6 months. And I've actually kept people on them if they were doing well. I've tried taking them off. And if they start relapsing, I keep them on. And then we go to like a year, and then we'll try taking them off again. And if it's no bueno, then keep them on. And a lot of these drugs, thankfully, are fairly safe. And many people take them long-term for things like genital herpes, or they may be organ transplant patients who they're trying to keep levels down. And so they can be taken for long periods of time, years. And so I do have patients who have just elected to stay on them indefinitely because every time we tried to take them off, they got worse. And so, but then some people, it's like, all right, let's give this a shot and then try tapering them off. And if they're not relapsing, great. And then let's see how long that lasts for. Because the problem with these kind of viruses, the herpes viruses, is that you always have them. There is the potential actually for eradicating some of them in theory. And there's some interesting discussion about that in terms of so there were some fascinating studies done where they looked at because like Epstein-Barr virus tends to infect B cells, so it kind of hangs out in the B cells. There's other cell types that it infects, but primarily those. And so when those B cells are infected with Epstein-Barr, they may migrate into the tissues because, and so they're kind of carrying Epstein-Barr virus with them wherever they go. And there's a thought that some of the reaction or the response or the ill effects of Epstein-Barr virus reactivation has to do with those B cells migrating into tissues and then the response that's happening there. Or possibly there is one study, and I would need to, so don't quote me on this one, but it's possible that in MS, which has been linked to Epstein-Barr virus, that when the B cells cross into the brain through a damaged blood-brain barrier, that they may actually, Epstein-Barr may be able to infect the neurons from the infected B cells. And so they're almost acting like a little transport unit. And but there are other mechanisms for why Epstein-Barr virus may be, when it's reactivated, why it may be causing problems. And another one is like, there was an interesting study in ME, CFS, and Gulf War syndrome patients where they looked at, they had a subset of them had elevated antibodies to the Epstein-Barr DUTPase. Some people call it the D-uptase. And it's an enzyme that's made by Epstein-Barr. And so if your body reacts to that and it makes antibodies to try and stick to it and neutralize it, it turns out that this enzyme actually can trigger an inflammatory response in white blood cells. And it can also kind of interfere with gene expression, your own host gene expression, that helps with maintenance of your blood-brain barrier, and also that helps with preventing fatigue. And that's also involved in the metabolism and uptake of tryptophan, serotonin, and dopamine. All very important things.
Yeah. So that was very technical. So I'm just going to try and, so basically what he's saying is the viruses, so Epstein virus, the virus that causes glandular fever, just for anyone who has not heard of that before. And so what you're saying is once you've got these viruses, they can often lie dormant in the body, and then something can happen later on and they become reactivated. And then they can hide in the tissues. They can sneak across what we call the blood-brain barrier, which the blood-brain barrier normally stops things from sneaking into the brain. And it can cause like inflammatory reactions. And therefore, treating these reactivated viruses is really tricky because they hang out. And viruses are so clever. Like they have got mechanisms by which they just stay in the body and they hijack the cells of the body, and they find ways to keep replicating. And that's why COVID is such a clever virus. It does that very, very well in multiple tissues. And so I guess what you're saying is the treatment it's going to be very much trial and error. Sometimes people need really prolonged courses of these antivirals. And then some people are on them for life, and some people you might be able to stop them and see what happens. That kind of a fair summary?
Yeah. And I think, I'm just speaking from my own experience about the total duration. There's other providers who may be like, no, I never continue people beyond 6 months. There's a colleague of mine who's an infectious disease clinician, and she's like generally 6 to 18 months. And so it seems to vary a lot by clinician. And it's really something you just have to look at clinically, like what side effects might they be having and what benefits are they having? And you kind of have to weigh those, as well as the risks of just being on the drug. Now, again, thankfully, the risks of some of the drugs are fairly low long-term. But for instance, something like Valsite, there may be more complications associated with being on that one longer term, as opposed to something like Valtrex or Famvir. It's really just that balanced clinical decision, having discussions with your patients about what are the risks, what are the benefits, and kind of moving forward step by step and just adjusting based on how the person's doing.
And have you found like good results from using the antivirals? Because I guess I don't have like lots of patients who've had access to them, because it's very difficult in the UK to get access to these drugs. So I don't really have a sense of who's improving and who's not, and like what the outcomes are. And I know there's a few studies, but in your real world experience, what do you find? I mean, I suppose the answer is going to be it varies. It's like,
well, if I have to look back, so overall the ME/CFS, so this was like pre-COVID, the people I was treating with the antivirals, I was seeing about 50% of them were responding positively. And
I mean, that's a lot, right? That is a lot. That's a high percentage for any drug and any intervention.
yeah, and again, some people it was dramatic, life-changing. Others it was less, less stark of an improvement, but still an improvement, a notable one. And what's interesting is what I was kind of noticing, and all of this ended up lining up with the studies and the literature, was that basically I wasn't necessarily seeing per se improvements in some of the antibodies against the viruses, which I first confused me, but then later as I read the studies in more depth, I started to realize why. Dr. Lerner explains this beautifully in his studies, where he's basically talking about how, essentially in this, again, it's very complicated and like really getting into the weeds, but essentially things like Valtrex and famciclovir, where they kind of inhibit the expression of the viral proteins, like kind of where it gets stopped, is sort of after certain proteins are already made that are expressed during the latent phase. And so certain antibodies, you just wouldn't really expect those to go down because it's not going to stop them being made.
Yeah.
Now,
so I guess that makes it very hard to physically measure a response. So for anyone we're losing slightly in this conversation, we're talking about antivirals and we're talking about reactivation of viruses causing some of the symptoms of ME. And people with long COVID, one of the theories is COVID can cause the immune system to be suppressed and cause activation of these viruses. So we're talking about using antivirals to treat that. But I guess what Jen is saying is we don't really have any good ways of measuring whether they're working other than kind of how people are feeling, because the antibody tests aren't very reliable because there's lots of variables. Is that kind of fair?
Yeah. And yes,
yeah.
And the antibody tests just aren't the greatest, to be honest. Like you can track now if you have IgM antibodies against, let's say, viral capsid antigen and EBV. There was one study that did see those go down in people who were treated. Also, generally speaking, if you have a positive PCR test, so you have actual, you have actual viremia that's being detected, that also should improve. But in my experience, I have not seen positive PCRs in the vast majority of the people that I've tested, and other colleagues have had similar experiences. There was a study by Dr. Peluso and colleagues where they looked at basically long COVID patients, and they didn't really, if I remember correctly, I don't think they really found positive PCRs. It was more like they found antibody levels that were elevated, and that people with those elevated antibody levels tended to have more like neurocognitive symptoms and fatigue after several months after COVID. There was a study in France in severe COVID patients who were in the ICU. Now, in those cases, they say they found viremia. Now, mind you, these are super, super sick people. They're in the intensive care unit. They're very, very ill. And they found that Epstein-Barr virus reactivated. They found that HHV6, which is another type of herpes virus that a lot of us have. That
viremia, just for people who don't know, that's kind of when you got lots of virus in the bloodstream and you can really measure high levels. It's like active infection. So, yeah, I mean, this is a really fascinating area. And I think Jen, you and I could chat about this all evening. I'm just conscious that we've got like more stuff to get through. So whilst that's really, I'm so interested in what you're saying, I think we're going to move on because I think we're at risk of possibly getting too deep into the technical aspects. So what I might do, because it's just getting to sort of halfway through, and I do definitely want to give the audience a chance to ask questions, is bring Helen back onto the stage and see if she's got any questions for you, just general questions. Hi, Helen.
Hi. Thanks so much for that, Jen. Really, really useful stuff. It is incredibly complicated, though, for somebody who's got a huge amount of brain fog and symptoms going on to kind of follow a lot of the deep dive stuff. Although a lot of us who have been on this journey now since 2020, or who are part of the chronic umbrella of conditions who have unfortunately been here much, much longer, do know a lot of it already. So it's really hard to gauge the audience and to what level to kind of come in at. But if we could bring it back to basics of what you can do, which is, of course, the name of our channel, for someone who geographically hasn't got access to all those tests, is there anything that you would recommend that you can do at home that is kind of a low risk kind of option, if that makes sense, of things to be mindful of, like really taking it back to basics, basically?
So in terms of like specifically addressing viral reactivation, or, okay. So one thing, I mean, these are very much the basics is, and I know there's issues with sleep in ME, in long COVID, is trying to make sure you give your immune system the best possible chance of functioning at the best it can. So getting good sleep, trying to go to bed at a regular time. And I know sometimes the sleep schedules are flipped, but at least trying to get as many hours of sleep, like get at least 8 hours of sleep if you can. And additionally, making sure that you have a balanced, nutritious diet. Now, I understand people have food sensitivities. They have things that they cannot eat. But this may be something we're working with like a nutritionist to say, okay, you can't eat these foods because they set off your symptoms. But here's the ones that you can eat, and let's make sure you're getting enough of all your vitamins, your minerals, your macros, like protein, carbohydrates, because if you become nutrient deficient, your immune system is not going to work very well, and it can't keep these viruses under wraps. So those are key ones. The other thing, stress reduction. Now, stress reduction is very challenging when you are chronically ill. A lot of things become extremely stressful that may not have been stressful before. Like, for instance, just trying to get groceries can be an extremely stressful experience where before you wouldn't have thought twice about it. So things like various kinds of mindfulness, meditation, yoga nidra, especially like if you're bedbound and you can't really do any kind of movements, yoga nidra is all just in your mind. It can be very, very like mild and adapted to what you can handle. So I know some people like can't tolerate music, but for those who can, just calm, very like gentle music to allow yourself, train yourself to be able to jump out of the fight or flight response, to let your body get back in, because the autonomic nervous system impacts how the immune system functions as well. So trying to allow more of a vagus nerve predominant rest and digest system to kind of kick in can be helpful. There's several other things too, like I know it's hard too when you're very ill and going outside can be hard, but getting sunlight so that you don't become vitamin D deficient, or if you can't get outside, making sure to take vitamin D so that you don't develop a deficiency there.
Yeah.
I'd say those are some kind of basic ones.
Absolutely. Yeah, no, great. And all yoga nidra in particular is great. It's interesting because, of course, some people will look at that and think, oh, well, that will cure you. It's like, no, obviously that's not going to cure you, but it will give you the foundations to get better if you're able to do certain things. So it's good to take it back to basics. Thanks for that.
Yeah.
So Jen, there's a few questions. Sorry, Helen. A few questions coming in about BC007 research. So Jen, I don't know if that's something you've got experience of. You want to make a comment about BC007?
I mean, I don't really know much about it beyond just what you kind of see on social media cropping up, just that, kind of what it is. So I don't know if I'd be the best person to go over it.
Yeah. I think that's fair. There's very small studies, and it's been promised as this potential kind of amazing drug for ME, but I think ME is so complex that until we have got the basic fingerprinting techniques to say, well, this person has this combination of factors and therefore they might be eligible for BC007, I don't think it's going to be the panacea. It's not going to be the cure. And I think that's kind of how it's been badged a little bit on social media.
Yeah. And, it's the GPCR autoantibodies are super fascinating, and I think they could very much play a role. The only issue is that between testing just GPCR, they're very complicated receptors, and they're very hard to create tests for because those receptors unravel when you try to put them in a lab environment. And so there's several groups working on testing. Like, this has kind of been a goal of many people to try and create one that's really reliably in the right conformation, so that when you test it, you know that you're actually binding the correct thing and you're detecting what's really there. And then also, and one that can tell you whether or not the antibody, when it binds to that receptor, is actually affecting the activity of the receptor, the function of it. And that is yet one more challenging step. So it's hard at baseline to even just detect the antibody, and then to try and detect a functional one can be even more challenging. And so I think part of this is going to be what sort of tests are they using to screen people for it. I know there's one they're using for that. There's a whole story kind of behind that, but it's one that I think would end up taking an hour to discuss. So.
Yeah, and just for people who don't know, the GPCR autoantibodies, they're kind of important in the autonomic nervous system. This is what we were just talking about, like the vagus nerve response, sympathetic, parasympathetic, that they're important in those responses, which we know are very dysregulated in any and long COVID. Helen, back over to you.
Yeah, I've got quite a specific one here, and I'm curious myself, actually. So this is in regards, you mentioned about the breathing tubes essentially collapsing earlier. And does that include the nose? And is that a red flag? And I'm curious, actually, because I've been trying those nose strips and it's really helped me personally. So I'm curious as if there's any correlation there at all.
Yeah. So, I mean, one thing, if you've got, so the nasal tissue, if you've got kind of, there's multiple reasons why that may actually collapse. So those nasal strips are a great thing to try. Those are very easy, like try them if you can. Just make sure, get them wet before you peel them off, especially if you have very soft or gentle skin. It may take a layer off if you don't. Now, really for like upper airway resistance syndrome, generally speaking, we're more talking about kind of like the upper airway sort of up here. But if your nose is collapsing at night, what can happen is that, sorry, there's just like fly attacking my hair right now. Like, okay. Oh my gosh, it's like so distracting. Okay. And so basically what happens is if your nose is collapsing, it forces you to breathe through your mouth. And when you breathe through your mouth at night, your tongue can actually fall backwards. Now, our tongue, I'll kind of turn sideways for this. Our tongues actually are quite big. They actually go all the way down and they attach kind of down in here. So they're quite large. And so the very back of your tongue actually can kind of press into your airway if it starts sliding back. So imagine you're lying on your back in bed and your mouth is open. Your tongue can just kind of slide back there and partially, this fly is lyric. And it can just slide back and partially block that airway. So the airway, which normally would look like this, starts to look like this. And so you're breathing through, imagine like breathing through a straw instead of breathing through your mouth. And so that's causing your diaphragm, the muscles in your chest, it's causing a lot of things to work much harder. And that can increase blood pressure. That can cause you to pee out more more of your blood volume. So you'll pee more because your kidneys are kind of getting, they don't really know what's going on overall. They're just like, oh, wow, I'm getting a lot of pressure. I should just offlet some of that pressure and help the system out. But if you have POTS and now you peed a bunch in the morning, now you have less blood volume. And so now you're getting up and you're like, whoo, why am I so dizzy? Right. And so it can contribute in a lot of ways. It can also elevate pressure in the head. That's seen in true sleep apnea as well. So there's a lot of, Dr. Andy Maxwell has some really interesting lectures about this and put a paper out there called spiky leaky syndrome, where he talks about this theory. It hasn't been fully proven, where you have low blood flow to the head when you're upright. And then you may actually have increased pressure in your head when you're down if you've got this upper airway resistance syndrome. There may also be CSF leaks. It's very, very fascinating. That paper is super worth a read. But yeah, I think this is one of the reasons why, someone may not necessarily hit the bells and flags for full-blown sleep apnea. They're like, no, I don't snore. I'm not overweight. I don't have a huge thick neck. I'm not an older guy, but you can still have this causing a problem. So
I have a couple of things to add. So in my day job, I'm a respiratory physician, but I was really never taught anything much about breathing in my training, believe it or not. Yeah, loads about the lungs. We don't get taught about breathing. That's like a physio thing. And there is so much to breath that's so important for health. Like, forget ME and long COVID, just health in general, but also in ME and long COVID. So for example, breath is kind of it's a measure of our autonomic nervous system. So, I give you some bad news, sympathetic nervous system kicks in, I'm relaxing, parasympathetic, right? So in sympathetic, out parasympathetic. And it's so important. We'll be doing a different session on this, but breath work's so important for regulating your nervous system. Nose breathing versus mouth breathing. So over the last 400 years, our jaws and our throats and our nose and nasal passages have all got smaller and smaller and smaller compared to our ancestors. That's led to a lot more problems and resistance in the airway. That leads to all sorts of stuff, high blood pressure, sympathetic overdrive, all of that kind of stuff. So even just taping your mouth up, there is a whole kind of movement around mouth taping at night, just a tiny little patch to prevent mouth breathing at night, because mouth breathing just stimulates the sympathetic nervous system. It's a brilliant book called Breath by James Nestor. He's actually a journalist, so he actually describes all this quite complex science stuff really in really simple terms, and I recommend everyone read that because it's a great book. But that's the whole other session we could do on breathing and heart coherence breathing and regulating the nervous system. It's free. Everyone can do it at home, and very, very powerful. So,
and,
yeah.
Speaking of breath, I mean, hyperventilation, so breathing too quickly, is something that has been noted in certain conditions, including a subset of people with ME. I believe they're also seeing it in long COVID, especially when upright. And so I don't think we fully understand why that is happening. But one of the things is when you breathe very quickly, you actually blow out too much CO2, carbon dioxide. And we usually think carbon dioxide's a bad thing, like, oh my gosh, carbon dioxide, it's pollution, right? But actually you need a certain amount of it in your body for your body to function properly. And one of the unique things that carbon dioxide tends to do is that if you have too little of it, you actually constrict the blood vessels that go up and feed your brain blood. So you lower the amount of blood and oxygen that's getting to your brain. And that's something that's been demonstrated in ME. There's some really great studies where they did tilt table testing, and they took ultrasounds and they looked at the arteries in the neck and the two arteries coming up the back by the spine going into the head. And they found that they kind of shrunk down. And so there was less blood flow to the head. There's a really awesome device that's coming out to try and look at blood flow to the head. It's more going to be like a wearable device to start. It's called Lumia. I'm super excited about that. And I'm on the list to get one. And one of my patients was in their beta test group, and super interesting. But blood flow to the head is like one of the things that's a problem. So like in the ME/CFS patients, even if their blood pressure and heart rate was stable when they tilted up, they still dropped about 25% of the blood flow to their head. And so, if you think about, okay, if your brain just suddenly loses 25% of its blood supply and oxygen very quickly, you're going to feel brain foggy. You're going to feel tired. You're going to be really fatigued. It's going to be hard to do anything. And then when you lay down again, it's like, okay, laying down, they didn't recover right away, especially the severe patients. It took them a while to actually recover. And how long it took them to recover that blood flow to their head correlated with how severe they were. And so there's this kind of thought that, can we do things to help improve the amount of oxygen getting to the brain? And there's quite a few. So some of the breathing exercises, there's folks looking at like rebreathers to try and like increase the amount of your own CO2 that you re-inhale to get the CO2 up a bit. Different breathwork techniques. And also there's like a few other things going on there as well. But that's just a fascinating topic that I think is going to be very front and center going forward, especially also with the brainstem findings in long COVID and the work that's being done in ME. Brainstem, very critical to a lot of the base functions of our bodies. So things like breathing and stuff like that. So if you've got brainstem issues, breathing may be affected. Do we know if that's exactly what's causing some of the hyperventilation? At this point, I don't know if we really do. But I think that's just an area of like keen interest to me that I'm keeping an eye on very closely.
Yeah, it's really fascinating. And I think the carbon dioxide issue, because normally, just for people who might not know about ventilation, you breathe the oxygen in as our energy source, and then we blow out carbon dioxide as our waste gas. But actually, carbon dioxide is really, really, really important to give up oxygen to the tissues as well. So if your carbon dioxide levels are low, you're going to hang on to oxygen more. And so it's another really important reason, other than the one you've just given, Jen, about why carbon dioxide, not over breathing. Because if you over breathe, shallow breathing from your chest rather than your diaphragm, you can have low CO2 levels, which is bad for all sorts of reasons in this condition. So doing the breathing work, the diaphragm work for the nervous system, for blood flow, for oxygen is really important. And not just in ME and long COVID, this is in other conditions as well, right? So this is not unique to this condition. I think it's just really overlooked generally. It's like the autonomic nervous system is just neglected in Western medicine generally, which, considering it controls all of our body's automatic functions, is quite astonishing, really.
It is an amazing system, and it's so pervasive. It's like, you know, I sometimes compare it to like, and this isn't even a great example, but like air traffic control at an airport. It's like controlling where everything's landing and who's going where and all the stuff and when, you know, all the coordination and timing. It's just so critical. Yeah. And
also I heard a really nice description of the cranial nerves, which are really, really critical to the functioning of our autonomic nervous system. And a lot of them come out of the brainstem area and function from that brainstem area. And the cranial nerves are kind of useful for everything humans kind of needed for hunter-gathering. So looking, listening for danger, chewing, swallowing, digestion, breathing. It was kind of, you know, all of our really, really essential functions for survival. And these are the things that kind of go wrong in chronic illness and definitely in long COVID and ME. So there's a comment here about vagus nerve stimulation, which again is a really, really promising treatment for ME and long COVID. But actually doing breath work, doing cold water therapy, doing mindfulness, all of that also stimulates the vagus nerve. So these are good things to do alongside medical approaches, and they're free and you can do them at home.
Yeah, we do recommend vagus nerve stimulation to our patients, the majority of them. And, you know, there's different devices you can use. But again, yes, some of these devices can be quite expensive. And so there are other ways of accessing the vagus nerve, like you said, that are free.
Great. There's so many more things that we need to get onto in very little time. Do keep the questions coming. Apologies if we haven't got onto everything. Just to finish that topic up really quickly about breath work and oxygen. One of the questions is HBOT. So that's the oxygen therapy in a hyperbaric chamber, for those who don't know. Would you recommend that? Personally, as a patient, I found it great, but obviously that's an individual response.
So, you know, this one, I've actually used HBOT for a long time for my ME patients and some of, you know, previous to the COVID pandemic. And, you know, one of the things with HBOT, so there have been some studies in long COVID showing that they're relatively small, showing some benefit and showing the benefit lasted for quite some time, even after they finished the sessions. Now, the thing is that some people I found kind of don't have a good response to HBOT. And so generally what I recommend people do is they go in and they do a very short trial session. And usually if you're going into a good clinic, they will let you do that. So they'll kind of, they ramp up the pressure very slowly on your first time, because it's something to adjust to. But then they may just keep you at the pressure, and they'll do a kind of a lower, you want to get, maybe about like 1.8 atmospheres or so, and kind of hang out there for maybe like 15, 20 minutes, see how you're doing. And then they'll do a gradual ramp down on the pressure, gradually bring you back down to sea level pressure, and then see how you do. And the big thing there is going to be like, how do you feel? Give yourself the next day or so. Now, mind you, if you made a big trip to go to the hyperbaric place and get into the chamber and stuff, and that wiped you out, that's another thing to consider, is that if the travel and like getting there is causing a PEM crash, that's something to balance.
Yeah, definitely.
That's one factor to keep in mind, is that, what is the trip there looking like in the trip? And, but if you're doing pretty well, generally kind of what I've seen, and I don't know if this generalizes, so this is just my experience, but I've kind of seen either people are like, okay, I didn't really feel much from it, or oof, I did not feel great. The people who are like, I didn't feel great, I'm like, let's not do this further for you. The folks, and some of them come out of there going, oh my gosh, I feel amazing, even after like one session. So I typically say start with a baby session, real short, test it out, see how you're doing. Then you can go back and do another one that's a longer time. And again, do that same experiment with yourself. How am I feeling? How am I doing? And if you're feeling bad, I wouldn't necessarily keep doing it, because some of the things is that like it does rev up metabolism. It's going to lower blood sugar a little bit. It does increase the amount of stem cells that release into your blood. There's a lot of really amazing things that HBOT does. But the question is whether or not your specific body and your physiology can handle it at that point. And so I think just dipping your toe in the water like that, like trying a real short session, just doing one more and seeing how you do, and then listening to your body. If it's telling you no, I wouldn't keep going.
Yeah, that's a really good rule of thumb in general, I think. Like I have a lot of patients who have just persevered. They've gone, I know HBOT might be good for me. So then they feel awful and they just carry on and do like 20 sessions. And then they spent a lot of money and not got any better. And so I just think that's great advice.
And it can help at different times in your journey. I've had times where it's just the PEM has made it much worse. It's not been worth it. Even though I wanted it to be helpful, it wasn't, because I wasn't ready for it. And other times it's been amazing, and I felt like a new person after. So I think being mindful that it's not going to be a straight journey always as well. On that note, if I could cut in with the next question, Binita. Because I think this is relevant to so many people. This is one, I don't know how to highlight. If you could do that, Binita, for me, that'd be great. From Matt Parsons. How do you get someone out of absolute rock bottom, so bedridden, communication very difficult due to high sensitivity to noise and light?
So this is tricky. And, I've had some patients who are in this state. And, depending, in my experience, we kind of like, we're trying different treatments. And generally speaking, it can be very hard to try treatments when someone, especially if depends on also if they're sensitive to different treatments and medications. Some people when that's a compounding factor, that can be really tricky because it limits what you can try. But it's sort of like, this is where something like, can someone like this start on a little bit of breath work, a little bit of yoga nidra? Like, can they do some of these things to start getting their autonomics in balance, work on things that don't require any light, don't require any sound, that they can just do, doesn't require really much movement. Start working on those, making sure they are resting, but then looking through and really like, okay, what treatments can this person do? Can someone quietly bring them in pills, food, making sure their diet is on point, things like that. And really, I've seen different things pull people out of this rock bottom state. Like sometimes it's been one patient who was distinctively, it was T3 thyroid hormone, was night and day. And there are others who it was like antivirals. There's some who, it was this like gradual time. I don't know if there was any one particular thing that really kicked it up, but really like in those things, it's like, okay, making sure the things that you can do are really like dialed in do the things you can, but keep treating. And, you know, that's,
I would add to that, just keep on top of the basics, because I've been there for a long periods of time, you know, and it's when you can't even sit up, it's very difficult to drink water, to then be able to, if you're crawling to the bathroom because you're not able to walk to the bathroom, you're not able to keep on top of your hydration. If you're not on top of your hydration, how on earth is anything else going to work? If you can't eat properly, how on earth is healing going to happen? So it's so hard, but yeah, good luck to anyone who's in that position, and keep going.
And I have got one patient who was completely bedbound with double ear, double eye defenders, and I'm hoping he's going to be able to tell his story soon, who is now up and about, is able to take, you know, is almost able to open his eyes in a normal brightness, is listening to music again, is starting to write again. And it's been a year of just slowly introducing different medications, and he was lucky that he didn't have gut issues, because I think the people who have the gut and nutrition issues, it's 10 times harder. But it is possible to lift out of the fog with the right support and treatment. But the problem is that is massively lacking in this country, and we've got very few clinicians who are able to, who A, have the knowledge, and B, have got the means and the knowledge to actually treat. But there are a few of us trying to treat this group of patients. It's so incredibly challenging. It's really hard as a doctor to try and treat this group of patients as well.
It's challenging because, like, you know, they can't travel, they're too sick, you know, they can't even really talk to you sometimes because, like, the light from the screen even is too much. So they usually have someone who's an intermediary who's doing that. And so one of the things one of my patients did was they'll like record on their phone, like on a recording thing, and they'll just record when they can talk, and they'll try to just tell me what's happening and what they want to talk about. And then I'll listen to the recording and we'll go over it with a family member. And then we can kind of communicate that way. So it's like passing back and forth, or even get like an old school tape recorder that doesn't have any lights on it or anything. Like, that's one way that people in the state can communicate. One other thing, and you know, this area perhaps has some controversy around it, but I have definitely seen this reverse patients out of ME, is craniocervical instability and like tethered cord, like the structural neck components. And I do always wonder, the people with who go into a bedbound state, it's things like looking at how bad is their blood pressure when they're upright. When they try to sit up, is their blood pressure absolutely tanking? Because sometimes IV fluids can be a helpful thing, like getting them on IV saline 3 times a week, or even daily in some cases, like just to get them out of that hole, so that they can actually sit up, is one thing. The other is a cervical spine collar trial. So just like, you know, even if they can't go out and get like one that's a hard collar, there's little inflatable ones you can get, and you can kind of fit it behind your neck and just sort of have someone else, because it'll probably put you into PEM, pumping it up, blow it up for you, and just very gently, so it's not like stretching your neck at all, but just having a collar so it's stabilized. Is this person able to actually sit up? Does the light sensitivity and the sound sensitivity go down? Because if they do, I would be very keen on looking at, okay, do they have some instability in their neck? Have the ligaments gone lax because of something that's happened? And because then if it's like, oh, they can sit up with a collar on, but not with one off, then it's like, okay, let's start MRIing that area and like use the collar. While you're in a collar, you always want to strengthen the muscles, because you start losing stabilizer muscle strength if you wear it for like longer than 4 hours at a time. But that's another thing that when I hear that, I'm like, is there neck stuff going on?
Jen, I'm so glad that you've brought up CCI, which is the cranial cervical instability, because it's very much a dismissed diagnosis. We don't have any expertise in this country. It's not really seen as a thing. I think it's kind of been something that's been adopted by osteopaths over the years, and osteopaths and, you know, traditional doctors don't really work together that closely, certainly not here. Maybe they do in the States a little bit more. But I do think this is a problem in my patients, definitely in some of them, but I can't get anybody to really investigate it or take it very seriously. And people are too sick to travel as well, so we can't prove it. But I think it's really validating to hear you say the words and to say, try this, because that's not something I haven't heard before, is the kind of the inflatable collar. So thank you for that.
Yeah, no, the expertise in that is especially in people who have comorbid connective tissue disorders. There's very few surgeons who will look at it in a different context and do the testing and do the surgery. I think most of them are in the US. There's one in Spain. I think there's a group in Italy doing some things for tethered cord. There's a surgeon in India, but I don't think I've heard of someone in the UK doing it.
And are people with hypermobility or EDS kind of at higher risk for that? Are they the most likely patients?
So I've seen it in both people who are not hypermobile and people who are. However, if your tissue is already stretchy and already lax, it's going to take less of an insult to cause it to slide even more. And so having something like that show up, I think connective tissue disorders, just to me, like physiologically would be a higher risk. Like you're kind of starting with already partially there.
Yeah, and we know COVID is definitely doing something to collagen. I've seen people with kind of acute scoliosis, acute hip pain, like just things that have happened immediately after infection, and that's happened in some children even, and we just don't understand it very well. So yeah, we're way over time, and I've kind of let it run because the conversation was so interesting. There's more questions.
Just one possible mechanism for why COVID might be going after connective tissue. Again, this is theory, but I believe Dr. Bolognese and like Dr. Ruhoy, they were doing some work looking at tissue samples from people that had been operated on for CCI. And they're trying to look at, is it possible that mast cells, when they activate, are releasing enzymes that are actually like acting like a meat tenderizer, and they're kind of like chewing up the connective tissue. Because chymase can activate matrix metalloproteases, which can break down the connective tissue. So that's like one possible mechanism. And so if you suspect that's going on, you have someone you can't get to a surgeon, and they're just like in a collar, looking at things that stabilize the mast cells, testing them for mast cell mediators and stuff, that may be a way to go to just try and slow things down as much as possible.
Yeah, I mean, I do find that mast cell treatment really does help a lot of patients with joint pain and with some of, that collagen type symptoms. So I think that's something that you can treat at least and have a go at. So yeah, it's interesting that work is kind of ongoing. I'll be interested to see how that pans out. Okay, we are going to have to stop. There's all sorts of questions that have come through. But I'm just conscious we've gone over the hour. And I'm normally really good at finishing on time, but I was just like, it's too good a kind of conversation to cut short. But seriously, Jen, thank you so much. I mean, I think there is just so much more we could discuss with you from your experience, but we're really grateful for you to share that with us today. And I hope it has given people some hope that there is a lot of good work going. There are guidelines out there. Yes, they might not be in our country, but they're accessible. People could use them. They could take them to their clinicians and, at least try, and we can try collectively with all of our voices to push for change. So, massive, massive thank you. And I think all it remains is just to say goodnight to everyone, and we'll be back in a few weeks' time. And I've completely forgotten to look up what the next session is, but we'll be a really good guest, I promise. I think it might be Tanya Dempsey actually, talking about mast cell activation, and she's based in New York. But that's going to be a great session. So thanks everyone, and we'll leave it there. So good night.
Thanks so much, everyone. Thanks so much, Jen, as well.
No, thank you guys.